Welcome to my podcast, The Laura Dowling Experience. Many of you will know me from my Instagram page at Fabulous Pharmacist, where I love to shine a light on topics that people normally shy away from. Today I spoke to GP and menopause specialist Dr. Caoimhe Hartley. Caoimhe and I had such an in-depth discussion about menopause. There is nothing that we didn't discuss. Should HRT be taken by us all for the rest of our lives? What is HRT? What are the symptoms of menopause? What can we do for low libido? What can we do for vaginal dryness? All of those topics have been talked about and answered. You're going to get a lot out of this podcast, ladies, I guarantee you. To support the Laura Dowling Experience, please check out our sponsors in the podcast notes below. Enjoy the show. Caoimhe, thanks for joining me today.
So happy to be here, Laura.
Yeah, it's great. I was really looking forward to this conversation because obviously menopause has become quite the hot and sexy topic, shall we say. And you're a specialist. So I thought we'd just get you on and get cracking on it. So tell me what it is. What is menopause?
Well, I suppose menopause is a normal part of a woman's life. Just like puberty, we see hormonal change happening. That is usually the end of our reproductive life. So typically and I'm averaging here, but from the age of about 45, we start to see changes in how your ovaries produce hormones, in particular estrogen. And instead of producing estrogen in a nice sort of up and down pattern, in a cyclical pattern from month to month, that usually coincides with ovulation, we see a change in how frequently you ovulate. So it might become less regular. We see overproduction of estrogen at times in perimenopause, and then underproduction at other times. But ultimately, at menopause itself, and menopause is just the term we give to your final period. On average, that's about 51 is the average age for menopause. And at that point, your ovaries stop ovulating and they stop producing estrogen. And then we get symptoms because of those changes.
Okay. But in the perimenopause, in that lead up to that menopause, we're experiencing all kinds of symptoms as well, aren't we? And I think that's the period of time that people have the most confusion about.
Yeah, and clinicians too, I think. It's hard for us too, because it's a difficult picture to tease this out. For a lot of women, the symptoms can really creep up on them. So you might get an irregular cycle. That would be the most obvious objective symptom that people would see. Their periods have gone from a 28-day cycle to something less regular. And that might mean they're more frequent actually. And for other women, they're further apart. So it's really variable. And what's happening in the background is really erratic hormonal production. And that creates PMS type symptoms for most women. So you might notice a pattern where, I used to get a bit of breast tenderness and I'd get some bloating and my mood would be a bit off for a day or two before I get my period. But now I'm noticing it's for 2 weeks before my period or 10 days before my period. And it's much more dramatic. My mood is awful. I'm really irritable. My breast tenderness is really pronounced. But again, highly individual.
Okay. And, it's great that we're doing all this talking about it. But I've had people coming into the pharmacy and I've had friends saying to me, I'm actually scared now. I'm really scared. I didn't know I was going to be facing all this awfulness. And that's the kind of the message that I don't think we should be getting out there, because I think, like you said, it's a natural part of the woman's body, of the woman's life. And we don't want trepidation around it. We want to be able to manage it. And we know that some women get very bad symptoms, but others sail through it with minimal symptoms, if any. So can we help to ease people's peace of mind here as well, please?
Yeah, you're absolutely right. I think if you look at the statistics, they say about a fifth of women will have severe symptoms. And I think by severe, they mean symptoms that are really impacting their quality of life. Their ability to work, their ability to enjoy their life, their ability to have fulfilling relationships, etc. And then you have about a fifth who have very few symptoms. So obviously their periods will change and then stop, but they may not get hot flushes. They may not get the mood changes. They may feel well throughout this entire time of transition. And it has no impact on their ability to function or enjoy life. So that's 40% in total, with, half on the higher end, the severe end, and the other half on the kind of asymptomatic end. And everybody else, the other 60%, are in between. Okay. And they've symptoms that are there, but maybe not so severe that they can't enjoy anything.
Yeah.
And it shows you how individual it is. It's a bit like, and I hate when people compare menopause to puberty because they are two very different things. But like anything, they have similarities. So if you took a 9 or 10-year-old and girl, for example, and you were thinking, okay, well, you know, she might start having periods in the next few years, and she's maybe started to have some changes in breast development or hair growth, and you want to prepare her for what's to come. You wouldn't sit her down and say, look, there is a tsunami of awfulness coming your way.
Yeah.
No, you would try to give her information, arm her so that she's prepared to know what to expect, what is normal, what she maybe wouldn't, you know, need to be discussing if there was an issue. So, you know, periods can be painful. They can be really heavy, but for lots of women, actually, they're fine and they can manage. So I think we should have a similar approach to menopause. It's, you want to educate someone and prepare them, but you don't want to terrify them either, because that may not come to pass at all.
Yeah, no, I agree. And I think that, like, I suppose for the problem that we have now is that for years it wasn't discussed, or it was taboo, or women, you know, couldn't properly articulate how they felt because they felt they'd be considered to be crazy, or, you know, there was that thing where, you know, we know not so the distant past, women were put into, like, you know, institutions because they were maybe experiencing some of the psychological symptoms of menopause and they weren't being looked after. And then we had the whole HRT thing where it was given initially, then it was like considered to be really dangerous, then it was not given, so an entire generation missed out on it. And then women going and presenting to doctors with low mood, etc., and being given antidepressants. So now there's an entire pushback and people actually turning up to GPs wanting, almost demanding HRT, and they may not necessarily need it. So I'd really like to get into that discussion because I know that you and I both have opinions on that.
So really, that's a discussion about women's health in general. If we just sort of separate it from menopause for a second, because my background is women's health, more general women's health. It's where I started.
Yeah.
And I love women's health. But I remember being so angry when you look at the history of women's health, and it's not just in Ireland, across the world. And like, even, you know, the word hysterical comes from hysteria, which is the Greek word for uterus. So like, there's always been this kind of snide, eye-rolling insinuation that everything female and hormonal is, you know, well, sure, aren't they all just a bit crazy, and this kind of stereotypical caricature of a menopausal woman. And but it's wrapped up in how women were treated for years. If you look at research, a lot of the research that was done into women's health was done on men. And they just decided we'd extrapolate from that to women, because sure, it's kind of the same. It's not the same. And there was one really famous study called the Baltimore Longitudinal Study of Aging. Doesn't really roll off the tongue, but this was a study done in the States looking at aging. They were trying to look at various parameters and the impact aging has on our bodies and different trends of aging. And they only enrolled men. And when they were asked about it years later, it's actually still going on, that study, and they have women in the study now, thankfully. But they were asked about it, and the lead researcher said, well, men are easier to study. And which is probably true, because we vary from month to month. Okay, but like, that's important.
But sure, lots of clinical trials, you know, have done that, because men are easier to study, because with our fluctuating hormones, a clinical trial may have a different outcome, because women may experience different symptoms depending on what time of the month she's given the drug or vaccine or whatever. So yeah, if you read Invisible Women, anyone, you will, I've read that twice. There is an entire section on drug clinical trials and on the medical profession and everything, and it is absolutely astounding.
Wasn't there a section about testing, like with crash test dummies?
Yes,
and that they were only used kind of the male body type.
Yes, and that's the reason why a lot of women would, if they're in crashes, they are more severely injured, because crash test dummies were tested on men and male bodies, and the height of women and the way our bodies will move in an impact. It's
Jesus
just,
Christ.
I know, it's just, it's unbelievable. We have accepted it for years, but we are slowly changing. And I think that's why there's almost this anger now that's come out about the menopause and about the fact that people feel that they haven't been looked after correctly, and that they now want to be
angry. Like, I'm angry about it, because if you look at pain relief for women in the hospital, so pain relief in labour, and this whole sort of attitude, well, if you have an epidural, you've somehow, you know, you've gotten out of jail, or you've kind of copped out of going through labour pain.
Yeah.
Like, what absolute nonsense.
Oh, it's terrible. I
remember my mum telling me I have an older brother, and when she was in labor with him, that it was horrific, really painful. And I don't think he was breech, but he was a difficult presentation. So she had a really tough time. And the midwife or whoever was looking after her at the time telling her, just offer it up for your sins, love.
Oh, for God's
And my mum,
sake.
a stream of expletives.
Oh my God, I know.
And just being so angry that and fair enough, that was back in the day. But now we have such appropriate and safe interventions for pain relief for women. And thankfully we do offer women really good pain relief in labour, but it took so long for that attitude to shift.
Yeah.
But we see it in general practice. Coil insertions, so Marina coil, Kylena's and Jadessa, the IUD that we do for women, we'll often not give, a lot of women aren't offered pain relief for getting a coil inserted. Why?
I don't know.
Why not?
But sildenafil was shown to give pain relief for
I did not know
period
that.
pain. No. But they didn't continue studies on it because it's almost like period pain isn't studied properly enough, and therefore the pharma companies can't extrapolate out whether or not they'd make enough money on it. So it was, the researcher in that cohort was trying to get funding for it, but couldn't. Tried twice or three times to get funding for it, but couldn't, and then it was just left. So there are many ways throughout the years where women have been left at a disadvantage or not looked after properly.
Look at endometriosis, same idea. And then I see it in my practice. I would probably see it in the perimenopausal women with really heavy bleeding who come in saying, oh, it's so heavy, I can't leave the house. I had a woman who was telling me about, I can't get the bus to work anymore because it will seep through to the seat of the bus. And so what do I do? Do I bring a towel with me to sit on? I have to bring 2 pairs of trousers.
Yeah.
Everywhere I go for 5 days a month, or, and the pain of that as well. A lot of women, it's not just how heavy and the flooding and the actual heaviness of the bleeding, but the pain that goes with it too.
But even the anemia as well, that will go with something like that.
And the chronic fatigue that happens from the anemia. And they put up with it because they feel there's this narrative out there that it's normal. Everyone gets their period, love, get on with it.
Yeah.
And I'm not saying that we should all have leave from work every month to sit at home with a hot water bottle and, nurse ourselves and over medicalize it. But I do think for women who are severe and it's impacting them, we should allow them access to the right conversation and the right medication and the right treatment.
But it's that whole thing about women's bodies being just that little bit more complicated than men's bodies, isn't it?
Yeah.
And that entire thing, and then the workforce, and companies will be looking at that going, well, if we have protocols for, say, period days, well, sure, everyone's going to be taking the mick then, and everyone's going to go off on their period days. I do think there needs to be a better conversation around this, though, definitely. Going forward for our daughters. Well, I don't have any daughters, but for my granddaughters.
Well, but for your sons as well,
exactly.
That they understand. And I think, educating the men in our lives, it isn't all about just getting this education out to women. The men need to understand it too. They're in work, they're in our workplace, they're in our families, they're in our lives.
100%. Oh, I'm big into my boys know everything about the female body.
Yeah.
But let's get back to HRT then.
Yeah.
And your thoughts on HRT, and what does HRT first? What does it do for people? How can it help? How long should people be on it for? There's loads of questions around it. So we'll see where the conversation goes. And
so HRT is hormone replacement therapy. Now they've actually started to move away from calling it HRT, depending on how kind of politically correct you want to be, but they call it MHT now. So menopausal hormone therapy.
Okay.
And the reason they've removed the replacement, is because we use hormone therapy for perimenopausal women who are still making their own estrogen. So we're not actually replacing anything.
Okay.
And it also, I think it implies a little that we're giving you estrogen to the same level you would have had when your ovaries were functioning. And actually HRT is much lower dose than that. So they found it was a bit misleading, and that's why they've changed the terminology a bit. So menopausal hormone therapy, or I still call it HRT to be honest, out of, habit, is usually a combination of 2 hormones. And the backbone of this is estrogen.
Mm-hmm.
And it's the loss of estrogen at menopause that we think drives most of the significant symptoms and the changes that we see in long-term health with that drop in estrogen. So the backbone of your kind of mainstay of your HRT is giving someone estrogen. And obviously there's different types of estrogen and there's different routes to, different ways of giving someone estrogen. This is where it gets really complicated. For women who have a womb, so if you haven't had a hysterectomy, we need to give you a second hormone. Estrogen causes thickening on the lining of the womb, and ultimately that can lead to womb cancer left unchecked. But if we give you a second hormone called progestogen, we stop that from happening. So progestogen, its main job is to basically switch off the estrogen receptors in your lining so that when you're taking estrogen for all the other benefits it has, it won't have that effect on the lining of your womb to thicken it, and we keep your womb safe. And actually we see probably lower rates of womb cancer for women who are on HRT versus not on HRT because the progestogen is so good.
And is the progestogen, like people can take it orally, vaginally, or they can have the Mirena coil put in? So what's the best option, do you think?
Yeah, so it can be very confusing. There's different types of estrogen, there's loads of different types of progestogen, and then there's different routes for all of these things. So when we say HRT, it's kind of an umbrella term for actually lots of different medications where it gets really confusing. That's where a lot of the research is confusing.
Yeah.
Because they've studied something we're not using anymore, But there is a gold standard. So I do the same prescription 90% of my day. Huge fraud. I'm doing the same prescription over and over again. And the reason is there is a safest form of hormone therapy. And that is to give someone estrogen through their skin. So that's called transdermal estrogen. So that's usually in the form of a patch, which would be changed twice a week, a gel, which is usually applied on a daily basis, or a spray.
Okay.
And again, the spray is daily. You can take estrogen in a tablet form. People would be familiar with taking the pill, for the contraceptive pill, for example. The big difference is that the tablet form of estrogen is metabolized by your liver. And when your liver has to break down that estrogen, it produces more clotting factors. So we see an increased risk of blood clots and stroke if you're on tablet estrogen. And we don't see any increased risk of blood clotting and stroke if you're on dermal estrogen. And there's a few other subtle differences too, but that's the main one. And then,
is there a difference between the estrogen that women will take for HRT and estrogen that women will take for the pill?
There is. So most pills, bar one or two, contain ethinyl estradiol. I'm telling you all this and you know all of this.
But I need to ask the questions so people can understand it. So it has to be like an interview conversation.
I know I feel silly like explaining this to the pharmacist.
No, don't. It's fine. It's fine. It's for the listeners.
So birth control pills contain ethinyl estradiol, which is a type of estrogen, but isn't the same type of estrogen that your ovaries produce. Old-fashioned HRT was a thing called, the brand name was Premarin, which people may have heard of.
I know.
And
horse
the name,
pee.
That's it. And the name comes from pregnant mare's urine, Premarin. And so they extracted, and a lot of our medication actually comes in this way. You say you don't want to know where half your medication comes from, but they would have extracted a type of estrogen from the urine of pregnant mares, and they distill that down and make it into a tablet. And Premarin is great stuff, really effective, like very potent. You feel fantastic, but quite high risk. Mm-hmm. So we've moved away from using Premarin. What we use now is called 17-beta estradiol. And when your ovaries make estrogen, they make 17-beta estradiol. And some people may be familiar with the term body identical hormones,
yes,
which is not a medical term, but is the kind of...
It's bandied around an awful lot though.
Yeah.
So can we explain how important that is or not important it is? Because you've body identical and you've bio-identical, and people are interchanging the two, and they think that, I think it's important that people understand the difference and how, important that is.
Yeah, so body identical hormones are hormones that have a chemical structure that is basically replicating what your body produces. So in this case, estradiol in your patch or your gel or your spray, or there is a tablet form of estradiol, it's a replica of what your ovaries produce when they produce estrogen. So it's body identical. Yeah. And from a risk point of view, it probably does make a little bit of a difference because your tissue recognizes this as something that is endogenous. It's like, oh, this is familiar to me. Mm-hmm. And it often can't tell, like your breast tissue, for example, might not be able to tell that this is something that you've put into your body as opposed to made yourself. There is one type of body identical progestogen, which is called progesterone, because that's what your ovaries make. When you ovulate, you produce progesterone. And we have a capsule version of that. The brand name is Uterogestin in Ireland. There's only one type, and that can either be taken by mouth or inserted vaginally. And then you have bioidentical hormones. So they're a different kettle of fish. I think a lot of the time people say bioidentical, and what they actually mean is this body identical stuff that we're talking about.
That's what I'm getting at.
Bioidentical technically are hormones that are made on site almost. So they're called compounded hormones. So now correct me if I'm wrong, because from the pharmacist's perspective, you could probably be much more accurate about this than I can be. But in my head, it's the equivalent of having a pestle and a mortar kind of thing. And
it is.
And you're individualizing it to the person.
Yes.
The big issue from my perspective is that you can do that with estrogen if you want. I'm not mad about using something that's that individualized. It probably doesn't make a difference to how effective it's going to be for you.
There's no compounding pharmacies in Ireland like that do that though.
See, they were all over Canada.
Yeah.
So I lived in Canada for 5 years and there was loads of compounding pharmacies.
But they're kind of coming away from that now, aren't they, over there?
Absolutely.
Because I have pharmacist friends over there that say that they actually aren't considered as safe as they originally thought.
Well, the issue is progestogen.
Yeah.
So a lot of the bioidentical progesterone, they try to give it to you through your skin. And they individualize it. So person A gets X amount, person B gets a different amount. And it's all based on and I'm generalizing, but it can be based on saliva testing and that's all nonsense. There's no evidence to it whatsoever. But if I try to put progestogen through your skin, as opposed to estrogen through your skin, if I'm putting the progestogen, the problem is you will absorb whatever percentage of that and it's unpredictable. If I put an estrogen patch on you and on me, we'll absorb different amounts. And the worst thing that will happen if I don't absorb it, I just don't get better.
Yeah.
So I'll remain symptomatic. But if I put progestogen through your skin and through me, and we absorb different amounts, I might not get enough to stop me from getting womb cancer.
Yeah.
So it has to be something that is regulated. And I know exactly how much you're getting every time you take it.
Yes.
That's the big issue.
Yeah, no, exactly. So I think that's important that people understand the body identical and what that was all about. So when people are coming looking for HRT, does HRT stop all the symptoms? Does it, make people feel amazing? Is it, they need to be doing other things we know in conjunction with it? They can't just think HRT and think life's going to be wonderful. But talk me through someone taking HRT and how it might benefit them.
Yeah, I mean, far and away, estrogen is probably the most effective treatment we have for menopausal symptoms, but in particular, hot flushes and night sweats. Mm-hmm. But even the joint aches and pains, potentially some of the skin changes and hair changes, although we've less evidence for that. Definitely for vulvovaginal symptoms, so dryness and painful sex. Localized estrogen for bladder symptoms, for needing to pee frequently, recurrent urine infections. For mood symptoms, depression, anxiety, estrogen may have a role for all of that.
Yeah.
So it's really effective. The problem is if somebody comes into the clinic and they say, okay, I'm 45 and my periods have started to change, and we tease through what symptoms they have, it is really hard to know how much of what they're presenting with is hormonal, how much of it is due to financial stress and work stress and life stress and other things. They could be clinically depressed. They could have generalized anxiety disorder that happens to occur or coincide with these hormonal changes. Estrogen will not fix anything that isn't hormonal.
Okay.
Sometimes the only way to work that out is with a trial of HRT, but you have to have an agreed plan.
Yeah.
Well, look, if you're not better after 3 or 4 months, stop the HRT. There's no reason to be on it if you're not symptomatically improved.
But what about titrating like the dose? Because sometimes it can take someone maybe 6 months to get what they need, to find what works for them. And I've had women coming into the pharmacy and they say, some days I wake up and I know I need 2 pumps of my gel, and other days I only need the 1. So it's kind of like they're self-medicating as well. So thoughts on that?
Very little harm to be done in a way, except you're creating more fluctuations. And what we're trying to avoid a lot of the time is fluctuating. Your brain doesn't like the fluctuations of estrogen. It's why we don't feel great in menopause. It's why we get PMS. It's why we get postnatal symptoms often with depression and anxiety. Really dramatic changes in estrogen. Your brain doesn't like that. It wants stability. It's why a lot of women, although I accept not all, but most women feel great when they're pregnant, because in your 2nd and 3rd trimester, you have this really stable, high estrogen, but stable environment. Mm-hmm. And that's, your body likes that stability. So I don't ever tell someone what they can and can't do. And if someone feels best doing that approach where they're kind of upping and or decreasing their dose, fair enough. I wouldn't recommend it.
Okay.
And I think we try to use, the easiest thing to use as a barometer is hot flushes and night sweats. And if they're resolved, you are adequately estrogenized. You don't need any more.
Okay.
But women, not everybody gets them.
I love that word, estrogenized.
Estrogenized.
Oh my goodness.
Yeah.
It's like, you have a meme for estrogenized.
Are you estrogenized enough?
I know, yeah.
Are you feeling estrogenized?
I love it.
But it's true. So if your hot flushes and night sweats are gone, well, then you are on an adequate amount of estrogen.
So what if someone isn't experiencing hot flushes and night sweats, but they're experiencing all the low mood, the low libido, all that, and the HRT could be helping that, but we don't know. It's
tricky.
It's really tricky, isn't it?
That's why we have 45-minute consultations, because it is really tricky. And I think you have to have a degree of logic. So if they come back after 3 months and say it has made no difference whatsoever, either the symptoms are not hormonal to begin with, or maybe they're not absorbing the estrogen that they're on, and that has to be kind of taken into consideration.
Okay.
Younger women often need higher doses. And so that's a degree of counselling about, weighing up with them. Look, do you want to increase the dose before we kind of decide, look, you're not responding to this?
Yeah.
For PMS, we use estrogen actually for PMS and for PMDD, which is premenstrual dysphoric disorder, a kind of more severe or extreme version of PMS. Mm-hmm. And high doses of estrogen have been shown to be really helpful for that because they create stability. That's the role of hormone therapy for perimenopausal women. Okay. You're producing your own estrogen, but it's all over the place, and that's making you feel unwell. And if I give you some estrogen, essentially that production of your own estrogen starts to settle down into a more kind of stable environment, and you feel better.
Okay.
But there's a lot of trial and error.
There is, and there's a lot of guinea pigging themselves, and doctors will, try and throw things at them. Not throw literally, but like they'll try certain things and then
flinging things at them across the room.
They may not work. And I think people can feel very disillusioned if they're not feeling better on it, but like you said, it could be to do with other factors in their lives.
And consider counselling and cognitive behavioural therapy. And like it's being open to, understanding that maybe this symptom or problem is multifactorial in its origin. It's not just because of hormones, it's due to hormones and other compounding factors. And so the answer won't be one solution. It won't just be HRT. Maybe hormone therapy plus counselling. Yeah. If you're clinically depressed, maybe hormone therapy and an antidepressant if you need it. But that's the individuality of it, is figuring that out. That's why my job is, I do the same thing all day long, but it's different. Every single consultation is different for that reason.
And then do the symptoms of menopause, so we couldn't discuss all 60 million of them, but do the symptoms ease once the menopause has happened, they've had their 12 months out where they've had their last period, and then they're considered to be post-menopause? Is the fluctuating hormones and all that change, is that only in perimenopause, or, when they're post-menopause, what's the story? Are they still going to have the night sweats? Are they still going to feel the low mood? Because post-menopause, they still don't have the estrogen, but does it settle?
For some and not for others is the kind of frustrating answer. So statistically, we think about 10 or 15% of women, they have hot flushes or menopausal symptoms for the rest of their life. Now, the other 85%, thankfully, do improve. Average duration in terms of symptoms would be about 5 to 7 years. Like, it's quite long, but that often starts in perimenopause. So before your periods have actually stopped.
Okay.
You tend to be your most symptomatic around the year before and the year after your final period. And what's really happening at the background is that because we think of menopause as being kind of all down here. It's my uterus and my womb and my ovaries. But actually most of your symptoms are neurological. It's your brain that is struggling and it's adapting to this new hormonal environment. There's really lovely research in the States looking at the neurochemical impact of estrogen, how important it is for our brains, how we, estrogen regulates a lot of our metabolism on our brains, how those cells use energy and how parts of your brain communicate with other parts of our brain. So it's really important for our brains. And then your brain has to sort of adapt to this new low estrogen environment when you hit menopause. And some women, probably genetically, never adapt. They never have that adaptation happen. Okay. And they continue to have hot flushes, for example, for the rest of their lives. But for other women, they do adapt ultimately. Okay. That's what makes it different from, because I often hear, you'll hear some of the UK specialists, for example, mention, well, it's like, your thyroid. If you stop producing thyroid hormone, you need thyroid replacement for the rest of your life.
Yeah. So what are your thoughts on that?
Same is not true for HRT.
Okay.
I think it's really individual. Obviously, there are a percentage of women who will either choose to stay on it because they feel better. And I think we should allow them have that discussion, and they should be, I think you make your own decision. And the risk is low. It's not zero, but it's low. And if women feel much better, I'm getting benefit from this, and they want to stay on it for life, I think that's their decision.
Okay.
I think there's 10 or 15% of women who will absolutely need it to stay well for the rest of their life. And if they're otherwise low risk, again, I think it's important they have that opportunity.
Mm-hmm.
But I don't think everybody needs to stay on it for life. I think there's definitely the majority of women at some point, if they stopped hormone therapy, will feel, well, that adaptation has happened in the background, even while they're on HRT. And then you stop their HRT and things are okay and they feel okay. And provided you don't have osteoporosis, if your bone density is okay, I'm not sure there is an indication to stay on it for life.
But what about the cardiovascular effects? And people are now talking as well about dementia, and potentially because more women suffer from dementia. Is that because of estrogen and the depletion of it in our brains, like what you're suggesting? So there was talk about, hormone replacement therapy potentially preventing dementia. And I know if that was actually really evidence-based, we'd all be on it.
Definitely. Yeah.
Yeah. So
controversial. Mm-hmm. I think anyone who gives you a definite on this is lying. Because there's so many unanswered questions to this. And one of the reasons is because of how heterogeneous, how variable HRT itself is. So what we know about cognitive changes in menopause, and actually that's really topical at the moment because with World Menopause Day happening, earlier this year, and they talked a lot about cognitive changes. That was the kind of big focus this year, was looking at the impact of estrogen on our brain. And we know it definitely has a role to play. And you're right that there's a genetic element here, in that women are twice as likely to develop Alzheimer's dementia, for example. Mm-hmm. Compared to men. Cognitive changes are one of the most impactful changes I hear women describe. They're one of the things I suppose we don't talk about probably enough in a way.
The brain fog, isn't it?
Brain fog, yeah, exactly.
And it's a very real thing. I get a bit of it myself from time to time. I do often wonder, am I perimenopausal as a result, or is it just that I'm just so busy? Do you know what I mean? There's a difference. And it's like that. It's like, I'm 42. Yeah. So I'm 42. Could I be perimenopausal, or is it just that I have 10 million things in my head, and that's why I've forgotten that one really important thing, like picking my child up from the football match,
Poor child.
But so... And I hear that time and time again as well. The brain fog makes people feel silly and stupid. It makes them very upset if it happens in work.
Yeah.
So I think that is important.
Hugely impactful on your confidence.
Yes.
But also really scary. Mm-hmm. I think it's a terrifying symptom to have. And I think women are petrified that this is the start of aging in their brain and the development of something like dementia. And like every other symptom, it's a spectrum. It can be really mild. It can be really severe. And all of that warrants a discussion with your GP or healthcare provider to tease through that. What we know is that it is a real thing. And one of the studies in the States show, and I sort of peddle this out every time I'm asked about it, but I think it's really fascinating. So they looked at PET scanning of women who were going through natural menopause, so hit menopause around the age of 50, 51, just a sort of normal natural menopause. And they scanned their brains, and they discovered that women who, they asked them to do cognitive testing. So they kind of fill out this, like a test that you sit and you get a score at the end of that. Women who reported worse brain fog, I have dreadful brain fog, my memory's awful. They were reporting more symptomatic changes. You could see that evidenced on their PET scans. So it wasn't that they were imagining it. There was something visible changing in their brain.
As in physically changing. Yeah. So
demonstrable. So it was,
my goodness.
It was objective. You could look at the PET scans and pick out the women who were going to have worse scoring or were going to report more symptoms in terms of cognitive function. And the other interesting thing was they did the same in younger women. So women in their 30s in this study who had oophorectomy, that had their ovaries removed and had a surgical menopause. And they went through exactly the same thing, the same changes on their PET scans. So they've basically removed this question over, is it aging?
Okay.
It's not, it's hormonal.
But then so if there's structural differences in the brain, can that be like undone?
Yeah.
So it can.
It's
they
transient.
can like grow back or whatever, or, uncalcify, or, what actually happens.
So it's a combination of vascular changes. So changes in genuinely like in vascular, I presume, flow, but it's at a micro vessel level.
Yes.
And the other kind of hormonal impact that it has on your brain. One of the theories is that your hippocampus, so you have a left and a right hippocampus, that your left hippocampus for younger women, we tend to use our left hippocampus. It's our memory center. It's where we get our verbal fluency from. And it's how we integrate new information. Or it's part of the structure of our brain that helps us deal with those tasks. And younger women on PET scans will be more left-sided for it when it comes to this area. They use their left hippocampus more. And if you look at women in post-menopause, low estradiol levels, they use both. So their right hippocampus, it's like it's just been booted up in menopause. It has to come online and it compensates.
Okay.
For the changes that happen. Your left hippocampus basically suffers with this loss of estrogen, but you have this backup generator on the other side.
Okay.
Now, if a neuroscientist is listening to this, they're probably rolling their eyes and I'm grossly oversimplifying all of this, but this is my understanding of it. And so the theory is that is the adaptation that's happening, is that there's a degree of time lag while, these reserves that you have in your brain, your cognitive reserves, come online. It takes time for that to happen. But most women, if you look at their cognitive scores, they have their starting point when they're premenopausal, regular cycles, normal estrogen production. Through the menopausal transition, they dip. And then depending on the woman, there's a variable timeline for this, but they come back to normal with no HRT, I should point out. Okay.
So that's actually a wonderful,
it's transient.
If people can take anything from that, then the brain fog doesn't necessarily last into post-menopausal and the rest of your life.
The problem is, and that's reassuring, I think, and I try to make sure that everybody leaves the clinic knowing that piece of information. I'm not sure that's helpful when you're saying, I can't put a timeline on it. It could be 10 years.
Yeah.
And it's a terrifying, but very impactful symptom at the time.
Yes.
And that's where treatment comes in. And going back to what you'd said about maybe HRT reducing dementia risk, I don't know, but nor does anybody else for that matter.
Yeah.
And the problem is the studies we have use HRT. They've looked at replacing estrogen in post-menopausal women. And actually, if you look at the studies, that's not very encouraging. We don't see this hugely, impressive change in the development of dementia or cognitive symptoms in women on estrogen from post-menopause, when they've stopped having periods. There is a suspicion that in younger women in perimenopause, when we know a lot of these changes actually start in perimenopause, well, maybe if we intervene with estrogen at that point, maybe that will translate to a reduction in developing symptoms, cognitive symptoms, but also maybe in reducing their dementia risk. But we don't know that yet.
It's very hard to even find, it would be very hard to even draw conclusions from that, because you're taking a cohort of people that you don't know whether or not they'd get dementia or not, and then you have to take them right through to their 70s and 80s.
But that's why you need large population studies. If you look at the Women's Health Initiative back in the 90s, that was a study of hundreds of thousands of women. And that's what we need. We need really large population-based studies. A lot of the research we have on this is observational. So it's people taking a group and then looking back and saying, well, what did they take 10 years ago? And what, we need randomized controlled trials. That's the gold standard.
Yes.
And to sit down and set out to answer the question.
And lots of them. And do you know, are any of them happening at the minute? Will it take them all the way through?
Yeah, I believe so. Yeah, I think because it is a really hot topic. And there is some observational evidence that would suggest in perimenopausal women, it may have an impact on their cognitive outcomes. I would never recommend to someone who comes in saying, look, I have a family history of Alzheimer's dementia and I want to prevent myself from developing it. Mm-hmm. I'd never say that's a reason to take HRT. It's not at this point in time. Being active and limiting your alcohol and not smoking and all these other interventions.
It's really boring though, Caoimhe.
It is totally boring. And you sound like such a party pooper, and I'm usually sitting there with a coffee cup in front of me, having not moved off my sedentary,
from your boozing the night before.
My coffee cup, which contains way more than coffee at 10 a.m. No, it doesn't. But and people already know this. Most people are really clued in as to the kind of lifestyle changes they should or should not do.
Okay. And
So
then
you're right, it's totally boring.
and then if someone is coming to you like in their early 40s, say they've got a few little niggly symptoms, but they're not the worst in the world. Like I think the whole menopause talk has had people thinking, Christ, I need to actually preempt this and treat myself now, you know, and prevent all these symptoms happening because I'm going to turn into, you know, a bag of cats. You know, my libido is going to be shot. I'm going to get depressed. You know, it's a case of it's not really ideal and it's not best practice either. Sure, it's not.
No, be sensible.
I think you find it very hard. I think you find it very hard to find a doctor that would actually prescribe it for you in those instances anyway.
Maybe so. I hope so. I think, you know, have a sensible discussion about it and have the indications for prescribing HRT. Like it's not that difficult. Women who are symptomatic and women who have osteoporosis. Like if you boil it down, they're the two main only indications for doing a prescription. What is tricky, as you say, is in the maybe early perimenopausal group and symptoms are coming and going anyway. And you might get 3 or 4 months of a stretch and you feel totally fine. And then you've a few months where you don't. And, you know, and so it is really difficult to pin down. A trial of HRT does very little harm. So look, if you want to do 3 months or 4 months of HRT, knock yourself out and see how you go.
Okay.
The biggest issue is not breast cancer risk at that age. Women under 50 on modern types of hormone therapy, and certainly if they're taking it for less than 5 years, probably don't move the dial much at all in terms of breast cancer risk. Because these are hormones we expect to see in your breast tissue expects to be in this environment.
Yes.
And we're not changing that by putting you on HRT if you're under 50. So the risk is not breast cancer. For women doing a trial of HRT under 50, the risk is bleeding. So if we put everybody, all women at the age of 40, you know, there's a nationwide public health movement, they all get posted out their HRT at the age of 40 and they all go on HRT, the issue will be huge amounts of bleeding, unscheduled, unexpected vaginal bleeding, erratic bleeding. They all then have to be investigated potentially. You have all these women going for ultrasounds and unnecessary hysteroscopies and unnecessary investigations. Bleeding is the bane of my life.
And are you seeing more bleeding now?
Tons.
Because people are on HRT?
Yeah, I feel like I constantly have to apologise to the gynaes as I walk past them in the corridor, like head down, walk of shame. I'm sorry, because we are seeing increased amounts of unscheduled erratic bleeding because that's a known side effect and risk with hormone therapy. So there's 2 ways of taking HRT. There's cyclical HRT, and that's for women who are still having periods. So you would take your estrogen all of the time, and the second hormone that we're using to protect your womb, you just take it for 2 weeks a month. And that is associated with continuing to have a regular bleed. Mm-hmm. The problem is there are some women who will have erratic bleeding around that because they're on HRT at all.
Yes.
For women who are postmenopausal, on average, they're over 50 and they've stopped having periods. We use continuous HRT. So they take their estrogen all the time and they also take the second hormone all the time. And the problem for a lot of them is same idea that estrogen will waken up their lining in their womb and the progestogen just might not be good enough at preventing bleeding from happening and they get breakthrough bleeding.
Yes. And then also just to explain that breakthrough bleeding or bleeding in general in a postmenopausal woman or erratic bleeding is indicative in some instances of issues there like cancer and things like that. And that's what
womb cancer is.
And
what
that's
we're
why you
about,
have to. That's why you have to send them for tests to the gynaes.
Yeah, I would kind of stress. Look, if it happens in the first 3 to 6 months after you have started your hormone therapy, we will probably not investigate it because it's so common. It's 80% of women will get some bleeding in that first 6 months, and we expect it to settle down. So we're really kind of paying attention to after the 6 month mark. And even after that, if you look at the statistics, lots of women continue to have erratic, occasional bleeding if they're postmenopausal on HRT. And the womb cancer rates on hormone therapy are really, really low. But your hands are tied to some degree. You know, if you end up having bleeding after 6 months, we do have to, like, how do I pick out the 1 in 1,000 who may have womb cancer? So we end up investigating. And that just, it creates pressure on the system, but it's hassle for the woman involved as well, you know. So I think you have to take all of that into consideration. The one thing we didn't mention, just estrogen on its own. So women who've had a hysterectomy, they get to take estrogen on its own. They don't need that second hormone because they don't have a womb to protect. The exception to that is women who've had endometriosis, particularly severe endometriosis, and we may choose to give them progestogen even if they don't have a womb. But for everyone else, if you've had a hysterectomy because of a prolapse or you've had fibroids or something like that, you take estrogen on its own. They're my favorite patients because
So easy.
Well, it's really straightforward. They do not get bleeding and they don't have any risk. So if you're taking estrogen through your skin and nothing else, well, there's no increased risk of blood clotting and stroke. There's probably no impact on the breast cancer risk, certainly up to about 20 years of use. So that's nice. And they get more heart benefit from it.
Yeah.
They get more cardiovascular benefit. It is all good. I'd still stick to saying, look, you should only be on it if you need it, if you're symptomatic.
Even with the cardiovascular benefit and the osteoporosis benefit.
Yeah, I think it's because, so if you've normal bone density now, but the cardiovascular benefit is not so dramatic that we should be flinging everybody onto HRT because of that.
Okay.
You take it into consideration, but it's not as impactful as being active, stopping smoking, all the boring things, watching your cholesterol, having your blood pressure checked. Those interventions have more impact on your cardiovascular outcomes.
Okay.
But it is nice to know.
Yeah.
And ultimately, like, I'm not a gatekeeper for this. It's not a, it's not a drug of abuse. Like, if people want to go on hormone therapy and they understand the risks and if they get benefit from it, they should be on HRT. Like, it goes back to the kind of how we approach women's health in general.
Yeah. And what about post 50 then? If they, just like a number of women say that they missed the boat with HRT, but they're still experiencing bad kind of postmenopausal symptoms, even, I suppose, if they're through the menopause.
Yeah.
Or, I've even had messages from people who say their mother's in her 70s. Is she too old to go on HRT? She's still miserable and still gets hot flashes. Like, what? I know there's the risk benefit, but do you see people coming in that are older, that are through the worst? One would consider they're through the worst, but they're looking for HRT now at like later age, 50s, 60s? Yeah,
I mean, it's a discussion like it is with anybody. We have, one of the things that's changed in the last kind of 15 years with hormone therapy prescribing is this concept of a window of opportunity. So we think there's a 10-year window from the time of your last period. The 10 years that follow that, you don't have the changes in your vascular system haven't happened yet. And if we intervene and put you on estrogen in that window of 10 years, we can slow down that progression of cardiovascular disease. Outside of that window, it's likely that you don't get an increased risk of heart disease if you start HRT at that point, particularly if your estrogen is through your skin, but you won't get the benefit. So if I have someone who is in their late 60s or early 70s who's still getting hot flashes, I ask myself two questions. One, is this definitely menopause? Is she that 10 or 15% who's just continuing to get them for the rest of her life? Or could it be something else? Like, it wouldn't be typical for someone to come in and say, I had really bad hot flashes. My period stopped at 50. They went away. I was totally asymptomatic for years, but now I'm having them again in the last few years. But that's not hormonal.
No. But if they were continuing to get them or continuing to,
they'd likely benefit from estrogen.
Okay,
then, yeah. And so, how impactful are those symptoms? If it's someone who's saying they happen once a week, they don't really bother me. Well, I'm not sure it's worth starting a medication for that reason. But if it is really impacting their quality of life, well, then it should be discussed. And the other question is, what is their cardiovascular risk? And so they are women we're much more strict about, and in terms of making sure they've had their cholesterol modified and checked and treated. They're the same with their blood pressure. Like, you look at all the other risk factors for cardiovascular disease and you nail them down. And if someone wants to do a trial of HRT at that point, I'd often explain, look, potentially the breast cancer risk is higher too, because breast cancer is more common in your 70s and 80s than it is in your 50s and 60s. So you have to take that into consideration. And your breast tissue hasn't seen estrogen in 20 years. And so it may respond or react differently when you reintroduce it.
Yeah.
But I mean, none of this
really isn't
black and white.
No, and it's not as easy to say, I want to go on HRT and that's the end of it. Like, there really needs to be an awful lot of considerations.
Yeah, I suppose it goes back a little to this kind of controversy now about whether, well, these are my hormones and I want them back.
Yeah.
Like, I agree with that to a point. And I'm all for, I think it's the woman's, once she's appropriately counselled, like, people need to make informed choices. That information needs to be correct and then they need to make a decision. Fair enough. I'm not sure that treating it the same as thyroid disease is the right approach to take here. You don't ultimately adapt to having no thyroid hormone. If we don't replace your thyroid hormone, you will continue to be symptomatic. Mm-hmm. Whereas if we don't replace estrogen, the majority of women at some point will no longer be symptomatic.
Because it's a natural process in the body. You know, we're designed to be fertile and then not be as we get older. And that's kind of the reality. But I think also, isn't it, you know, the truth is that say 100, 200 years ago, we wouldn't have lived very long past the menopause. You know, we were dying much earlier, but now we live much longer lives. So we could live half our life postmenopausally. So what's, you know, do we really want to be taking, you know, medicines?
But equally, do you want to feel awful for half your, so that's where it comes down to being sensible about the person sitting in front of you and not having sweeping statements about no one should have HRT or you can only take it for 10 years or like all of that is nonsense.
Yes.
Or that everybody should be on HRT. No, it's completely individual.
Yeah.
Which is great because that's what's so fascinating about it, you know, and it evolves.
Yeah.
Your body adapts and evolves over time and some people need it for life and some people don't.
With the vaginal symptoms though, do they adapt? Does the vagina adapt to? Okay. So I'd like to discuss that. Like, you know, with the estrogen pessaries and creams and that, is there definitely kind of an opportunity there for people to be on that for the rest of their lives to prevent those symptoms?
Yes, like scream it from the rooftops. Yes.
Okay.
So I feel very differently about vaginal estrogen. It's not HRT to begin with. It's not systemic. So what we're referring to is either pessaries that you're using vaginally or this cream, and there's a couple of other ways of giving people localized estrogen. Once that estrogen is absorbed through the vaginal tissue, it stays in the local environment. So it can affect your bladder, your urethra, so that tube going from the bladder to the outside, the vaginal canal itself, and the vulval tissue on the outside. That whole area absorbs, soaks up that estrogen and loves it usually. But it doesn't get into your circulation. It doesn't become systemic. And lots of women on HRT will also need localized vaginal estrogen, and it's fine to use the two together. And there's lots of women who don't need hormone therapy if they're not symptomatic, but do need localized estrogen. So, you know, your poor vaginal tissue, when you lose estrogen, it doesn't recover.
It's terrible really what happens. Like, and I'm saying that not to scare people, but like, I mean, people can have awful symptoms down below, can't they?
And I think because it's such a private, intimate thing, we're obviously much less inclined to talk about it.
Yes.
We see it often with smears. So people come in to get their cervical smear. They've put it off for like a year or two because they're dreading it. And they don't want to be awkward and say, look, I find it really painful. Because again, I mean, you know, sure, this is normal. It's part of being a woman. I have to just grit my teeth.
Just go through the pain.
No, please tell me if you find smears painful. It's really good for me to know that. And I would advise if women are postmenopausal and tend to find smears really painful, get some vaginal estrogen, even if it's only for a couple of weeks before you go in. It will make all the difference. So we tend to use, you know, for the symptoms like dryness and irritation. So it's not just dryness, but that feeling of being irritated or itchy. That's often vaginal atrophy, with a horrible medical term that we give to it. Makes you feel like it's just shriveled up and
I know.
You know, aged, but like that's not.
Has.
Well, I suppose like if I'm going to put a positive spin on that, hang on. But I hate the word atrophy. You know,
I know.
But that is what's happening. So the vaginal tissue, you know, it loses estrogen, it loses its flexibility. Absolutely, yeah, and it becomes thinner. It tears easier. It doesn't have the give that it used to have. The pH changes. We get different organisms living, like colonizing the vaginal canal and that environment. We see increased urine infections. The actual length of the vaginal canal shrinks.
You're selling this to me.
Sorry.
Really looking forward to it.
However, all of that is reversible with localized estrogen. Like it is so effective and so safe. Everybody needs to be on localized estrogen from 50.
I would agree. And there's so many women. And I think that thankfully we're now coming around. We're talking a little bit more about vulvas and vaginas and all these things, because for years they weren't talked about, and women did suffer for years, or they just didn't have sex, or they had pain wiping, or they couldn't ride a bike, or, you know, all of those things that really affected them.
Yeah.
And I've seen it, and I'm sure you've seen it. But, you know, I would agree with you that we need to be getting the message out there that women should be using this.
Ask for it.
Yeah.
You know, and it's not, like, I get that it's embarrassing, and I probably have a degree of, I mean, I talk about vaginas so much, and I examine vaginas so much. And so I'm probably a bit blasé about it, and I accept that it can be really embarrassing, but you have to ask for it. It is with this really effective treatment just sitting there. It's over the counter in the UK.
I know. I mean, maybe in about 20 years it will be here, because we're usually behind. But, if women can pick it up and just use it themselves as well, because I I've had one woman sticks out in my head who came into me in her 70s and she had issues with her vulva. And I told her, like, you need to go to your GP. Estrogen cream can really sort that out. And she actually said to me, oh, sure, my doctor doesn't need to see my vagina, you know? And I said, well, first of all, it's your vulva, actually. Your vagina's inside. So we need to be teaching women the proper and anatomical terms for their bits
I don't think
too.
men have as much issue with whipping it out, to be honest.
No, they don't.
If I recall from my general practice years
No,
and how
they
many I
don't.
used to see in a week, like, I don't think they have any issue with whipping it out.
So we need, like, women need, if you are having pain there, we really would urge you to go and get it seen. Pain, irritation, itchiness, like recurrent infections. And actually, you did touch on the UTIs. Sometimes women can experience the symptoms of a UTI, but it isn't actually a UTI. It's just the anatomical changes down there. Isn't that right? And
it's irritation, essentially. Yeah. The urethra has changed and you can get frequency. So you might feel that. And your bladder, the detrusor muscle in your bladder is covered in estrogen receptors. It's embryologically derived from the same tissue as your vaginal tissue. So it's just covered in estrogen receptors. And so it misses estrogen when it's gone. And it can make you feel like you want to pee a lot. And that's often the easiest thing to do, is to treat that as a UTI. It's not a lot of the time. The other thing is thrush. The amount of women I would see who say, oh, I'm really prone to, I get thrush all the time. And it's not thrush.
No.
And actually Candida, which is what causes thrush, Candida loves estrogen. It loves an estrogen environment. And when you get to menopause, the incidence of thrush, like the risk of you having thrush, plummets because there's no estrogen there. So Candida is like, well, I have no interest in this environment. There's no estrogen for me.
And in actual fact, if people, think they're getting recurrent thrush and they feel that they're getting symptomatic relief from the likes of the thrush creams like Canis and stuff like that, it's probably just the fact that it's a cream going on and it's not that it's an antifungal. So if you feel that you're getting recurring thrush, you need to get that seen too, because probably estrogen cream would sort that right out.
Or steroids. So sometimes there's other dermatological conditions that can affect the vulval tissue, way more common at the time of the menopausal transition. Things like lichen sclerosis, but even just like contact dermatitis or eczema or psoriasis, they'd respond to steroid often, but they have to be examined to be diagnosed. And if I have someone with recurrent thrush and we're really not sure, do a swab. So we do a swab and send it to the lab, and that tells you this is thrush or it's not. And you save yourself a fortune on Canesten cream and pessaries. And
100%. Yeah, absolutely. I want to talk to you about libido.
Okay.
How's your libido?
Oh, it depends on the day, Laura, or yourself.
But libido is a huge issue for women that are peri and, post menopause. It can affect relationships. I've heard women say they feel dead from the waist down. They would have had, great sex life, and then they suddenly just literally zero interest. And trying to explain this to partners or trying to even, I suppose reconcile themselves with it is huge. So I know there's lots of talk around testosterone gels.
Oh God, testosterone is the bane of my life.
Go on. Yeah, I want you to give out about it.
If there's one message, I think I'm aware of the privilege I have of talking to women about this all day long and knowing how common having a crappy libido is. And say if I see, 10 new patients in a day or whatever, 9 of them, if not 10 of them on average, will say, I have no libido. And if they don't mention it and I ask them, they will say, I've no, not just a low libido, I have no libido.
Zero.
And then I hear a variation of, I would rather ...
Yeah,
and it's different every day. I'd rather
run around Croke Park naked.
Either something awful or I'd honestly rather just put on Netflix and do whatever. And I think normalizing that for women is so important.
Yes.
Because I think we maybe have it in our heads that everybody else is out there like absolute rabbits.
Yes.
The kids are a bit older now and we've more space to ourselves. And why am I not embracing that with feeling like hopping on my husband every 5 seconds?
Yeah.
And I don't have an easy answer for that. I'm sure it is multifactorial. Poor sleep. If your mood is low, you've other stressors, you have shit to do that, just doesn't lend itself to having loads of time in the evening to lolling around in bed and, changing your relationship. Often, our relationships all evolve and so sometimes that plays a part. There's a host of different reasons why things change, but some of it is biology. It's quite normal. I'm not saying you should put up with it. But it's quite normal to not have a huge interest in sex at menopause.
As we get older.
No,
because
that's normal.
And I suppose, and I don't want to make out like women were only, all we're here to do is to have babies. But But by the very nature of making babies, you're supposed to be, you know, having sex. And once your fertility declines, I suppose, you know, although obviously there's a reason to have sex, it's lovely and it can make you feel close to someone and it can be great fun as well. There's no biological reason really, other than the great mood and stuff that you might get after it. But there's no real biological reason to be having loads of sex because you're not going to be producing babies.
Yeah.
So it makes sense if you were to look at it in a black
From
and
a
white
medical
way.
perspective. Yeah, I totally agree. Yeah. And I think it's more, and I'm like, you know, I'm not saying, and therefore it's not important, and therefore we shouldn't talk about it. I'm not saying that at all. It is so important. And it has such a value in terms of your relationship. And like you said, it can be great fun and all the rest. But there's nothing wrong with you if you don't have much of an interest. It's not, you know, there's nothing wrong with you. That's normal. However, so if it's bothering you, that's a whole different kettle of fish. So like if it's impacting your ability to enjoy, if you miss it, you know?
Yeah, exactly.
Then fair enough. Then let's have a chat. The first thing to do is actually look at the vulvovaginal stuff. So not go straight to testosterone, but to look at how comfortable sex is. Because if it's uncomfortable, which lots of women report, especially at menopause, and they say, look, I'm using lubricant and it's still really sore. That feedback to your brain is like you're wincing in advance of having sex. So that has to be dealt with. It has to be more comfortable. One of the changes with the loss of estrogen is the loss of vascular supply to the vaginal tissue. And so we see less blood supply, and that reduces how sensitive the area is. And if you look at the clitoris, it's this huge bundle of nerves, 80% of which is underground and you can't see it. But as it loses its blood supply, it loses sensitivity. And so vaginal estrogen actually helps with all of that. And sometimes that alone can help.
That's wonderful for people to know that. And I think it's important also to discuss the whole, like, women will often orgasm on clitoral stimulation. So if the blood supply to the clitoris is being reduced, then, you know, even if they do have sex, just to have sex, their orgasms may not be as enjoyable, or they may not be able to achieve them as easily. And that in and of itself is just, that's that vicious cycle of, oh, I just couldn't be bothered doing that kind of way. So I think that if we're considering, you know,
like, it should be pleasurable.
Yes, it should be enjoyable. And, you know, so there's lots of factors there. And you mentioned lubricants. They're so important, you know, that kind of, and getting in the mood and all the rest. But you know, the way with libido, it's hard to define it, but women will say, I literally don't want to have sex. Like it's a chore. Yeah. And I can't pretend that. Like I can't just like lie back there just because my partner wants it.
Think of your country.
Yes. So that in and of itself puts huge strain on relationships. Yeah. So it's so important for people to talk to their partners about it as well, isn't it?
Why don't we have more psychosexual counselors in Ireland and access to all of that? Like, I know. Because we're so in our, I mean, did you ever think you'd be doing a podcast talking about the clitoris and orgasms? And isn't it great?
It is wonderful, but it's really, you know, it's only now that we're kind of discussing it, because so many women, I feel so sorry for like previous generations.
Oh yeah, where it was all, I mean, I don't think you'd even chat to your friends about it, I'm sure, back in the day, but I think access to proper psychosexual counselling would be hugely beneficial. And now, not for everybody. There's women who, going back to sort of, well, this is very intimate, and some people are very embarrassed. Maybe they don't want to sit down with a total stranger and talk through this. But I think a lot of psychosexual counselling can be helpful and can help, you know, educate about pleasure and tease through, you know, why something has changed. It's really complex. Like, we're complicated. Men are so much, I mean, I get the researchers' point of view, but like, they're so much less complicated.
It's so true.
It is. But but that's what's so wonderful about us as well, is that we're not straightforward. And I think, like I'll have a lot of patients ask about testosterone. My libido's really low. Can I go on some testosterone? As if that's the entire conversation to be had. And looking at, like, there's medications that make your libido worse. A lot of antidepressants have a negative effect on libido. Oral estrogen has a negative effect on libido. So if you're on the pill, we'd expect your libido to fall.
Isn't it so interesting? And, you know, this is a conversation that I've had before as well, but isn't it so interesting that people go on the pill so they can have sex and not get pregnant, but in actual fact, it lowers their libido?
Is that part of how it works, do you think? But someone on the pill and their desire to have sex in the first place. I know, but
you know, you've women that may have been on the pill from their first sexual encounter all the way through to when they start having babies, and they only actually realize then that they have a libido. They've not really been enjoying sex as much. Like, you know, and you know, is that part of the patriarchy as well? Like,
conspiracy.
We could have a huge discussion. That's another podcast. I'll get you on for another one.
All on itself.
I know, isn't it? But you know, it is interesting. But it's that whole women's health issue that you can't just have a chat about menopause. It's about everything, really, isn't it?
Yeah, it's all encompassing, I think. Yeah. I mean, that's what I love about it. It is so involved, and, you know, it seems so specialized in one way and it's so generalized in another, because you're taking in someone's background, their life, what's going on in the background contributes. Testosterone has an impact and has a role to play with libido. Like, I'm not sort of, you know, dismissing it completely. It has a role to play.
Do they turn into like raging horn dogs when they're on it? Or
no, I think I'd be even busier if they did. I think people out the door.
And for some people it doesn't work at all. Sure, it doesn't.
For most people. Like,
for
just
most
being
people,
honest,
it doesn't work at all.
Yeah, I would think so. Yeah. So I'm all for it, because again, if you go back to look, what's the risk with a trial of testosterone? Well, nothing really. Like, if you do 3 months of testosterone, 3 to 6 months of testosterone. So testosterone's usually a gel. It's something that you're applying on a daily basis, and we usually apply it to the inner thigh.
You might get a few little hairs on your inner thigh from it.
Some excess hair growth can be normal. Acne, if you're prone to it, can be a side effect. That's quite common too. But most people, it's not that they have an issue or they get a side effect, and there's no risk with 3 to 6 months use, but they come back to saying it hasn't had an impact. I mean, for the few people that it does really impact, and it is the missing piece, well, then it's really beneficial that they're on it. We have at the moment no way of telling who is going to benefit and who won't. So I see it as an important part of that discussion around libido, but not the only tool that we have. And it isn't a fix-all by any stretch. But you know, I'm open-minded. I'd love a bit more research into testosterone. I don't know where we're going with it. You know? Yeah,
I'd love it too.
I'd love to know if perimenopausal women would benefit. We don't have that data at this point.
No,
we use
it. In most instances, it's given to younger women that go through menopause earlier. Isn't that right? Rather than women that go through it at the normal age.
Yeah, I suppose I'm open-minded. If somebody asks me for it, you know, you'll counsel them on the risks, like what we know about it, the fact that the benefits are there, but they're not overwhelming, like they're not totally dramatic. Whether it has an impact on cognition and brain fog and energy levels is unknown at this point, and it's all anecdotal. But look, the risk is low, and if you want to try it, you know, but we're firm that if at 6 months you've had no benefit, I think you should stop.
Yeah.
And you're right, for younger women, for women who've had premature menopause, that's about 1% of women under the age of 40, about 5% of women under the age of 45, their periods will stop, their ovaries will stop working. They often benefit. So testosterone is your third ovarian hormone, but it doesn't fall off a cliff the way that estrogen does. And that's why not everybody needs it and not everybody benefits.
Okay.
It just sort of gently you know, decreases. Peters out, exactly. From your mid-30s till somewhere in your 60s, and then weirdly increases, and we don't know why.
Is that why we see like hairs on the chin as we get a little bit older? That's
actually more to do with the ratio. So because you lose estrogen in a much more dramatic, abrupt way, even though you're losing testosterone, you lose it at such a slow pace that the gap between these two hormones, the ratio changes, and all of a sudden you have a lot more testosterone than you have compared to estrogen. And your skin often reflects that with excess hair growth or acne, which is a bit of a bummer in your 50s.
Oh God,
acne.
I know.
And hair loss, hair thinning, same idea. It's from that, they're called androgens, these testosterone hormones. And when you're androgen heavy, which is what happens at menopause, we see those changes happening. Yeah.
Can we do anything for hair loss in menopause? Because it can really affect some women, and it can affect their confidence. Obviously, you know, our hair is there and we love it, and we do so much to it over the years, and then suddenly it starts falling out, and it can be very upsetting. Is there anything that can be done for it? Like, does HRT help with the hair growth?
So hair is complicated. Hair is dermatological. It's part of your skin, really. And it sits in either a rest phase, a growth phase, or a loss phase. It's in one of those 3 kind of phases throughout your life. And it's kind of constantly turning over. It is a reflection of your health often enough. I think that's one of the reasons that it's horrible when it does thin, because a bit like your skin changing, you feel, I look unhealthy. Like I look, so iron levels are really important for adequate hair growth, or adequate iron, I suppose, levels are important for hair growth. So that's a blood test. Thyroid as well is the other thing that we'd often check, just to make sure if someone has hair loss that we're not missing something else correctable.
What's the percentage of ladies that are hypothyroid? Like, it's high enough, isn't it? And it's more, there's more women than men that get it as well. And it's usually in around the 50 years, isn't it? So it is something, just for anyone out there listening, it is very important to, like, if you're feeling tired and sluggish, if you are experiencing hair loss, if you are putting on weight, and you see all of these symptoms are very similar to menopause too. So, if you go to your GP, I'm sure they would do blood tests, and the blood test that they're doing is not for menopause, actually, because you don't do blood tests for menopause. It's symptomatic tests for menopause, isn't it? Yeah,
the only exception to that is younger women. We just want to confirm if their periods have stopped. Have they stopped because of a change in ovarian function that is menopause? And we check that. Outside of that, there's no indication to measure an FSH level, which is your kind of hormone level.
Yeah.
We do a lot of blood tests, but we do them for thyroid and anemia, and to rule out other things. I mean, I'd feel really stupid if someone came back to me and they're on HRT for a year and it turns out that we haven't addressed their low thyroid. That's contributing. So you do have to get other things checked too.
So in terms of the hair loss, is there anything that women can do apart from, I suppose, like, the eating healthily? The diet and exercise. I know there's the topical products that they can use,
like minoxidil, which is
like those kinds of things. But that's laborious and it's expensive. They need to use it every day. So is it just a case of they need to kind of put up with it?
So it can be driven by estrogen loss, and estrogen seems to have a couple of impacts. One is that it encourages hair, like more of your hair will be in the loss phase potentially than in the resting or growth phase. And the other thing is that because our estrogen seems to control our sebum production. So sebum is an oily substance produced in the dermis layer in your skin. And we produce it in hair follicles too. So the actual texture of your hair will change. It becomes drier because you've lost this natural oiliness with the loss of estrogen. So that's where HRT potentially has an impact, is it may encourage more sebum production and, ceramide production, these kind of natural oils in your skin and your scalp that may improve hair quality, and it may have an impact on hair growth, but it's not overly dramatic. I would, if someone has really profound hair loss, you look at the pattern of hair loss. Is it one particular area, like a patch? Is it generalized, which is more typical? And often we send them to dermatology because they can do scalp and hair biopsies.
Okay.
So they actually look at the hair follicle under a microscope to see what is underlying this, and that can be really beneficial. There's various interventions that they do that can be helpful.
Okay. No, that's good for people to know, because it's one of those things that kind of comes up, but people don't really know where to look for.
Do you know what's awful about the kind of skin and hair stuff? I think people feel, I don't want to mention it because it makes me sound really vain, but it actually has a huge impact on your confidence. It's almost like,
I can mention the pain, I can mention the other issues, but
it's somehow less legitimate or something.
But it is so legitimate, and I think that if it is bothering you, you need to, get it seen to as well. And then, is there anything to do with like diet and exercise that people can actually do other than being good, being good in inverted commas, that will help them through this?
There's some evidence for phytoestrogens, which are the plant-derived estrogens. They're often what are in a lot of the over-the-counter menopause supplements.
Yeah. But can people do people need to be careful taking them if they've had estrogen-positive breast cancer, or
technically, yeah, they do. Technically, you want to be careful with anything that's going to boost your circulating estrogen levels if you've had estrogen receptor positive breast cancer. Now, in saying that, the impact of dietary estrogens is probably so low you'd need to be like in a bath full of them per day to have any meaningful impact.
Okay.
Things like soya and tofu, not very appealing, I wouldn't think. But maybe to some people, not to me. But flaxseed is the other thing that's very high in these natural phytoestrogens. they all might have an impact. Vitamin D is a huge one.
Yeah.
Not so much for symptom control, but for bone health.
Yes.
And then adequate dietary calcium if you can.
And do people need to take a calcium supplement if they're eating their cheese and their yogurt and their milk and they're not in osteoporosis?
No, is the short answer.
Yeah.
Like if you're getting 1,000 milligrams a day in some form or another, 3 to 4 servings of something rich in calcium per day, usually that's, I mean, people know about dairy obviously being high in calcium, but also leafy green veg like broccoli and spinach and oily fish and almonds, and there's loads of other sources.
Yeah.
I think it's hard to be calcium deficient.
In Ireland, anyway.
Ireland. Yeah, sure. Everything is slathered in butter
Yeah.
and like, you know, and we're pretty good with our veg as well.
Yeah.
So yeah, dietary is probably best if possible.
Yeah. Okay. And then obviously adequate sleep, but we tell people about getting sleep.
As if it's as easy as
I
just
know,
like,
yeah,
I know, I
as well.
struggle with this as well.
And then our exercise. But can I just touch a little bit on people that have had estrogen positive breast cancer?
Yeah.
Because they often go through, you know, if they haven't gone through menopause already, they go through a really quick menopause, like a medical menopause, and it happens to them, you know, just out of the blue, because obviously if they've had chemo and that, it just affects their ovaries, and so they wake up one day and they've no estrogen, and it's very difficult to deal with. And what are your thoughts on them using HRT? Because now there are some clinicians suggesting that it's okay for these people to use HRT for a certain length of time to get them over, you know, a bumpy period, etc.
It's really tricky. They're my most complicated patients, I would say, for 2 reasons, just like you pointed out. The main reason being that they're the most symptomatic. Like, it's so cruel because they're the patients you're least inclined to give hormone therapy to, but they're your patients who are the most symptomatic for the very reasons you described, because they're often, whether it's chemotherapy or radiotherapy, they're plunged, you know, like thrown into ice water with menopause. And those symptoms can be really, really dramatic. On top of, please, you know, bear in mind being treated for breast cancer, like on top of coming through a treatment that can be quite difficult and you might not be feeling well. And then you have this, you know, the menopausal issue on top of that. So they're really challenging. And the other issue is that often if you've estrogen receptor breast cancer, you might be given medication then to take as part of your treatment.
It's just they've been hit from all angles.
So people might be familiar with tamoxifen, which is the most common medication that we'd see. Tamoxifen is a thing called a SERM. So its role is really to kind of prevent estrogen from having any influence or impact or effect on your estrogen receptors.
It's awful. It blocks them. Like, it's just
completely
horrible,
And I suppose the purpose really in the setting of someone who's had breast cancer is it will stop the breast tissue from having any stimulation or any stimulatory effect from your own estrogen. So that's tamoxifen. And then there's another medication. They're called aromatase inhibitors, which stop you making your own estrogen. And I don't know the nuances of all of it, not being an oncologist, but they're used in different categories of women or different types of women. And breast cancer itself isn't just one, even estrogen receptor breast cancer isn't just one type of disease. Sure, there's loads of very complicated ways of differentiating different types of breast cancer. So women who come into me who have a history of estrogen receptor breast cancer, I think the best place to start is to pin down what symptoms are the most problematic, and to look at what's bothering the most and try and target them. Vulvovaginal dryness, vulvovaginal symptoms, like we discussed before, they are women who can have localized estrogen, which is a bit controversial, but I'm going to pin my colours to the mast here and say, look, obviously you start with vaginal moisturizers and lubricants. I think the risk of using those localized estrogens is probably very low. Yeah.
Well, first and foremost, they don't get systemically absorbed. So that's the
Not
most
long-term.
important thing.
Yeah. You can see a little kind of, you can see a blip of their estrogen levels in the first few weeks after they start them, but not long-term. And that is kind of borne out over years of research. So provided they're using the normal prescribed dose of these localized estrogens, like no one who's had estrogen receptor positive breast cancer should be walking around with vulvovaginal symptoms. We can treat that.
Yeah.
The problems are all of the other symptoms. Vasomotor symptoms, which is the medical term for your hot flushes and night sweats. we have good non-hormonal medications, and that's a good place to start. So things like gabapentin, which is often used for pain. It's an old-fashioned seizure medication. Again, who am I telling? Like you're, but
no, but you're telling them. We're telling our listeners.
Have you heard of gabapentin, Laura?
I certainly have.
So it can be effective. We'd see a reduction of about 50 or 60% in how frequent the hot flashes and night sweats are. And it can be good for sleep. The problem is you end up using such a high dose of it to achieve that you give this poor person a whole host of other side effects. It's not very well tolerated.
No.
Antidepressants, that's one role they really do have in all of this conversation, is that they're quite good at reducing hot flushes and night sweats.
Can't they? Yeah.
And so that's really beneficial. But again, potentially have side effects like any medication, and they might not be effective enough for the women who are really severe. And there's a couple of other medications on this list as well. Oxybutynin, for example, a bladder medication. So we have some good non-hormonal medications, and there's a new one coming hopefully in the next year from the UK, I think called fezolinetant, but don't quote me on how to pronounce it. And
they come out with the most amazing names, don't they? Just make it sound easy, will you?
Like something straightforward.
I know.
Like I can think of loads of potential names that aren't fezolinetant, but anyway. And it would be the first medication that was specifically designed to treat hot flushes and night sweats. All of the other ones, it is just a happy side effect that they were designed for treating something else. And then we noticed, these women tend to get less or fewer hot flushes. So fezolinetant, whatever the hell it's called, it will be designed for treating hot flushes and night sweats. And the preliminary data seems to suggest that it is really effective and well tolerated.
That's great.
It is. But what do you do with the women who have the joint aches and pains, the fatigue, the brain fog, the mood change? Like for the symptoms that aren't vasomotor, that aren't hot flushes and night sweats, who've had breast cancer, how do we treat them? I have had the odd person that we will start hormone therapy because we've exhausted everything else, and her quality of life is so bad that she does not care that there is an increased risk.
Okay. Does she almost have to sign a disclaimer saying that though?
I don't do that because I feel that almost suggests I'm shirking responsibility. Okay. Look, sign that and then I'm off the hook somehow. No, like it's the same as any medication we're prescribing. We should be counselling women, taking responsibility for the signature you're putting at the bottom of the page and documenting that. We'll often suggest, if you can, bring somebody with you. Don't make these big decisions on your own. I mean, if that's what you want to do, that's fine too.
Yeah.
We don't insist on it, but we offer to maybe have someone else in the room. If you want to bring someone because we throw so much information at people.
I know.
It can be hard to digest, you know. And often it takes a few consultations to get there.
No, it is a good idea to bring people with you. I know when my mum was going through breast cancer and we would go to we went to a gorgeous plastic surgeon for the reconstruction, and myself and my auntie and my mum all turned up for the consultation, and poor Katrina was sitting there opposite us and she goes, I feel like I'm being interrogated. but she kind of should feel like she's being interrogated. But she was lovely because it meant that we could absorb the information that my poor mother couldn't, because she was still in a haze of this diagnosis. So I would encourage that. It's great. Bring your partner, bring a friend, bring your daughter, bring someone who can absorb and even write down some tips, because that would be, I think if anyone gets anything from this conversation, it would be that, wouldn't it? Yeah.
And I think we shouldn't work in isolation. So if every single person I have who has a complicated medical history, but in particular the breast cancer patients, I will make an effort to link in with their oncologist and their GP. Like we should all be talking to each other, because maybe there's something that the patient has forgotten to tell me that might be relevant, but their GP is aware of it or their oncologist is aware of it. You need everyone's input.
Yes.
I'm coming at it from one angle. Their oncologist is coming at it from another. Their GP is sort of coming at it from every angle.
I know. I feel sorry for the GPs in some ways, because some of them have got awful stick from the fact that, people have been going to them and they would have, they have menopausal symptoms, or they go to them 2 or 3 times and the GP maybe isn't a menopause doctor or maybe isn't the specialist. And, we're all talking about it now, but for years we didn't. And I suppose someone may have been going to a GP for 20, 30, 40 years, have seen them throughout their whole life. And then they're going with menopausal symptoms that may not be picked up, but the GP may have been reluctant to prescribe HRT, and the patient feels really hard done by. So, there is there are people saying as well, go to, if your GP isn't able to help you, it's okay to go to a menopause specialist for these issues. Like, what are your thoughts on that? Because I know that like in medical school even, or even like throughout your training, there isn't a lot of menopause training. Sure, there isn't.
That has changed. So the ICGP, the Irish College of General Practice, has embraced a lot of this. There's a new community gynecology course, and myself and a couple of the other specialists in Ireland have written the menopause element of that. I actually only we had a live session last night where there was 190, I think, GPs had registered for it just this year. And we had this live session where they can ask questions. It's all via Zoom at the end of the module. And it's brilliant. And there's huge interest. Yeah. So, but that's recent.
Yes.
So you're right. Historically, there wouldn't have been great. And I think some of the reason for that lack of interest in terms of educating GPs was because we didn't have a treatment that we thought would help. And so, like, what do you do as a GP if someone comes into you and all you've been told is, well, HRT is going to give them breast cancer?
Yeah.
You have no other options. We weren't great at knowing the non-hormonal options. So you didn't have much to talk about. And I think that created a lot of, maybe a lack of confidence from the general practice side of things. I have huge respect for it. I'm a GP, but like,
I know that. Yeah,
I found it so overwhelming.
I know. Yeah, but that's why I'm saying
everything.
Well, that's the thing. And GP by its very nature, it's general practice. So you need to know you're supposed, and people can come into you with a myriad of issues.
Yeah, yeah.
So it's like, how do you know absolutely?
Insane job.
It really is.
Insane.
And then, we're all human as well. So naturally a GP will have a special interest in an area of their practice. So it could be asthma, it could be childhood, but because menopause was not even really talked about or considered to be that important for so many years, we can't turn around and go, oh, my GP's crap because they don't know. Everyone is trying to educate themselves, from pharmacists to nurses. Like I see it, but on all my working WhatsApp groups.
But we have options now. That's why. So now there's no excuse because you have something you can offer women for the most part. I remember in general practice, my sort of Achilles heel would have been musculoskeletal stuff.
Okay.
So like sore knees, and I hurt my ankle, and I have a pain in my shoulder, and I could never get my head around the orthopedic kind of stuff. And I'm like, you'd see kind of on your list, I've 40 something people to see today, and I'd all the women's health ones. I'm like, okay, I'm good with them. They're grand. And peds, I was generally like,
I'll
the
take
kids,
a vagina any day, but a knee,
all
no.
of the vaginas. But when someone would come in with something like that, you'd, half the consultation, there's part of my brain thinking, number one, how can I get them out of the room so that I can then Google what they have come in with? Like, is there some way I can work in a urine sample into this conversation so that they can leave and I can look it up? Yeah. So I think it's normal to have.
It's so important that people realise that GPs are human too. And yes, you're right.
Rubbish at it. So much of, but I accepted that.
Yes.
And decided, okay, I'm thankfully not rubbish at the women's health. Like, I loved women's health.
Yeah.
And I loved that feeling of like the confidence I had at knowing a lot about this one area. So I have huge respect for GPs who basically know loads about
an awful lot.
Yeah, kind of. Right? Yeah. And probably are not all trying to send people out for urine samples so they can Google stuff like I was. It's probably a good thing I left. But.
Oh my goodness. And then, is menopause care easy for people to access, particularly public patients, say, that don't necessarily have the funds to pay for private practice, doctors?
It's changing, I think.
It? Yeah.
Yeah. I think the budget this year for women's health was really positive and really encouraging, even with the opening up of the free contraception. And I think that's a really positive thing.
Yeah, it's great.
From a menopause perspective, so I run a private clinic, which has always stuck in my throat a little bit. I don't actually love private practice, if I'm honest. In Canada, there was no private practice. It was a one-tiered system. Everybody had access to everything, and it worked really well. Although I presume, from the government's point of view, it was a very expensive system, I imagine.
Was it a little bit like the NHS system?
It was just a much, much better version of it. Yeah.
Okay.
And that's because where we were in Alberta, they had oil, so they had lots of money.
Yeah.
And so, people had access. Now, the only thing is they'd have a 2-week wait to get into their GP, but they didn't pay for anything. So they didn't pay for their general practice care. They didn't pay for their hospital care. They didn't pay for a lot of their medication. It's brilliant. Yeah, it is brilliant. But That's actually changed since we left Canada. Anyway, discussion for a different day. But that was my background in a way. Like I really kind of cut my teeth in Canada for that 5 years.
Okay.
And so I hated coming home then and having to factor in cost of medication, cost of access. You know, it turns out a clinic is expensive to run. Who knew?
Would you reckon?
A little, yeah.
But sure, even insurance overheads by their
and even actually my medical indemnity, I used to pay per month in Canada what I pay. Sorry, I pay per month here what I paid for a year in Canada.
Oh, that's
for my medical indemnity. Anyway, so I didn't really have a choice when I moved home except to go into private practice if I wanted to do primary care based, just women's health. And that's how I've ended up with the clinic that I have. What I'm really delighted about though is there's a clinic in the National Maternity Hospital, Harley Street, and I've just launched the clinic in the Rotunda Hospital, which is a public clinic. And the National Maternity Hospital, they'll only see complex care, which is great because we need somebody to do that.
Purely complex care. And by complex care, you're talking about those women that have a cancer.
Yeah.
And all those other...
Or maybe had a blood clot or stroke in the past, something like that. And so that's headed up by a few different doctors, and the lead clinician is Dr. Deirdre Lundy, who's fantastic.
I've never heard of her.
No, I'm sure no. Who's she? So Deirdre's great, and she led the way with this clinic in Holles Street. So the clinic in the Rotunda is a public clinic. We do see complex care because it's a specialist clinic and it's in tertiary care. We should be seeing complex care. It's part of our job, but it is also a public clinic. And I'm hoping that it will allow access for some women who can't afford to or don't want to go to a private clinic.
Yes.
But don't have complex needs either, but need to talk to someone, and maybe their own GP isn't the best suited to talk to them about this. So
and how do they get into that? Do they have to be referred by their GP though?
Yeah.
Okay.
So the GP would refer through a system called HealthLink, which is how the GPs refer to a lot of the hospital-based clinics. Yeah.
But with more GPs coming on board and training in menopause, there'll be more availability of them to help women as well. So
hopefully,
it seems to be that we're going in the right direction. Isn't that right?
I think so. Yeah, I definitely think so. And I think as that happens, potentially these hospital clinics become more suited to just doing complex care potentially.
Okay.
As more of the general practice, it mops up a lot of the public patients who maybe aren't as complex, but it's definitely going the right direction. Yeah. I mean, I'm busy, and I think that's a good reflection.
Goodness, I know. So how long did it take to get you on here?
Yeah, but isn't it great?
It is like great. It's brilliant.
Yeah.
And I think the more people that are talking about it, the better. And there's enough space at the table for absolutely everyone, so long as you're giving the right advice. Isn't that right?
Definitely. No, and that's it though. And you do have to be careful, I think, because as the media interest in it has grown, and you see these documentaries happening and all of that, it creates a vulnerability for a lot of spoofers and for pseudoscience and for people being told, stuff that is completely wrong.
Yes.
And the pendulum swings the other way. We go from telling, having no information to having lots of information, but some of it is rubbish.
And it's hard for people to wade through that.
So how do you sift through that amount of information? Yeah.
No, I agree.
Looking at the right stuff.
And what got you into, you say you loved women's health from the start. What got you into it? Was there something that you just liked it? Or?
Yeah, my mum was a bit of a feminist, so I probably got started on the path with her. And my mum would have been employed in Aer Lingus.
Okay.
And when she got married, she was no longer employed in Aer Lingus.
Oh my goodness. So
she's of that era.
That's like not long ago.
No.
Isn't it crazy?
No. And I think she never got over her rage at, the fact that the assumption was, well, you're off to have babies now, so you don't need a job. Anyway. So I've probably taken some of that attitude with me a little bit. And I don't know why I love women's health so much. I love women. I think we're fascinating, biologically even. I did gynecology training in Waterford Regional. It's now called University Hospital Waterford, I think. So I would have done a 6-month rotation through that department and loved it. And I've never ceased to be totally impressed by babies being born. I just think everything about reproduction is incredible.
Yeah.
And then what actually got me sort of hooked when I went to Canada, this dedicated women's clinic is where I worked, and they were all so inspiring, the women that I worked with. And it was so brilliant what they were offering. It was more skilled than we would have been seeing in general practice. But they weren't gynecologists either. It was this kind of brilliant sort of in between.
Yeah.
And then I got into fertility first, actually. So I worked in a fertility clinic in Edmonton, in Canada, where we were as the kind of GP. Like I was the first port of call. So patients who were referred in would see me first, and I would do some of the more, I'd do their workup, and I would do the medical fertility treatment. So things like Clomid and letrozole and ovulation induction. So not IVF.
Yeah.
But not everybody needs IVF. And that, and I suppose I had personal experience of being a patient in that setting.
Okay.
And so I got really interested in hormones, and then, it was an easy leap, I think.
You mentioned IVF there actually, and it has jogged something that I wanted to ask. Can the use of IVF and all of those hormones being pumped through women's bodies, can that trigger issues with early menopause or with hormones in general and knocking things out of kilter? Are they seeing trends like that? Because more and more women are accessing IVF now because we're having babies later. So is there any talk of that?
No, not that I'm aware of. So I don't think having IVF will change your genetic timeline for when you're going to have your last period or how symptomatic you're going to be at menopause. There is a connection though, because women who have lower AMH levels, which is a sort of measure of ovarian reserve, women who are more likely to have IVF. So if you have low ovarian reserve, you're not producing a huge number of follicles, you're much less likely to get pregnant on your own. They're more likely to have IVF. But they're also more likely, because of these changes in their ovaries, to have an earlier menopause.
Okay.
So there's a coincidence happening there, but it's not. The IVF hasn't given them a problem that's meant they've had early menopause. It's the reason they've had IVF in the first place is also the reason they might have an early menopause, if that makes sense.
Yeah. Okay. No, it was always something that I was, that's kind of brought up here, but you've just explained it very well, because obviously there's that reason. And
there's short bursts of hormones. If you look at IVF medication, it's really intense and it's really concentrated, but there's short bursts of hormones. You tend to be on hormones for, intensively for a few weeks, and then you're either successful or you're not, and you take a break. So I think the exposure probably isn't there to have any impact on things like menopause.
It's interesting. It brings up something else, because we're having babies at a little bit later, or a lot later maybe, women are saying, I got a message from one woman and she goes, I have a 6-month-old and I was at my doctor's and I'm actually perimenopausal, like I'm facing it. So, women are dealing with an awful lot, as well as the symptoms of menopause. And that's what we were saying, like how much of it is related to minding kids, minding our parents,
having a 6-month-old.
And then perimenopause thrown in as well. Yeah. So there is an awful lot to think about and deal with there, isn't there?
Yeah, you've a lot on your plate, really, don't you? Like, it's hard, adulting and all of that. But like, I think, what you don't need is the issues that come with perimenopause thrown on top of everything else you're dealing with. But equally, it can be very difficult to tease out what is hormonal and what isn't. And that's where the discussion really comes in.
Yeah, absolutely.
Being sensible about it.
Is there anything else that you'd like to say about menopause before I ask you the two questions that I ask all my guests?
No, I think we've covered.
We have, haven't we?
I think so, yeah.
I didn't even look at any of my notes, but I think we actually did cover it all in a roundabout way. Everything kind of fed into everything else, I think. So Caoimhe, it's been a pleasure having you speaking about menopause, but
Thanks,
I'm going to ask you, what advice would you give young people today? And what's the meaning of life?
Oh God. Okay. So just two small questions then, isn't it? Great. Okay. What advice would I give younger people? I think, education is going to, I'm sure this is probably a bit of a boring reply for you, but
no, not at all. Everyone has a different reply. It's amazing the differences people have.
I won't even ask what my other half said to you, but anyway, I think education is probably key. I think, when it comes to certainly looking at women's health, that's the bit that has been missing, is that they've been kind of told what to do a lot of the time with their health for a really long time and denied options. And I think if we give women the correct information and support them in making decisions around that, that is what we can do. But that needs to start at puberty.
Yes.
Not at menopause. It needs to start at puberty. You need to know what's normal, what's not normal. You need to know who to talk to if your periods are heavy or painful or sex is painful. You need to know what your contraceptive options are. You need to go and talk to someone about all of that. So I think arming younger women with the correct information sets them up, but it also gives them confidence, which is something that I didn't have when I was younger. And I think that would have made a huge difference.
Yeah.
You know, and what is the meaning of life? God, okay. Well, I don't know any more than anybody else. So I think starting with I don't know is probably a good place to start. I can tell you what the meaning of my life is, you know, and again, probably a very boring answer. I have 3 very lovely little kiddos. God, I'm actually getting emotional, Lord.
That's
Jesus
okay.
Christ, yeah. So it's them. Yeah.
That's lovely.
I have 2 little girls and a little fella that we are very lucky to have. Yeah.
That's lovely.
Yeah.
Absolutely, Caoimhe. You've been an absolute pleasure to have. Thank you so much.